Daniela, I can't hear you.
That's because I was muted. Thank you, Kristen.
You're welcome.
I'm going to start again.
Good job. Way to go.
So good morning, everyone, and welcome to our second day of virtual executive seminar. This session is called Creating Value Propositions with Kristen Woodlock. My name is Daniela Labate-Cavelli. I'm an IFRS employee, and I'm joined today by Ruth Cologne-Wagner, my colleague, who's doing tech support for us in the background should we need her. So just a couple of housekeeping things before we get started and sort of turn the controls over to our presenter. So right now, all of the participants came into the room muted with their video off. We would encourage you to continue to keep your line muted and to have your video off so that there's not so much background noise in the room. We do have quite a few folks on the line, and I'm sure others will be joining as well. There is a way to change your video settings to speaker view so that you can only see the speaker. You can do that by hovering your mouse over the video toolbar and choosing the Show Small Active Speaker Video option. So this meeting is being recorded. The recording will be available to all of the participants along with the slide deck after today. And participants will be receiving an email from NIAPRS with that information to download the recording and the slides. And again, just a reminder that CEUs are available, CEUs for social work, LMHC, and CPRP. So do fill out that evaluation when you get it in your email. Kristen will be taking questions at the end of the presentation, so I'll encourage you to chat in your questions using the chat box feature and chat them into all panelists. And finally, at the end of Kristen's presentation, I'm going to invite all of you to join the other Zoom room, the Peer Crisis Innovation session, so that we can be present for Harvey's closing remarks for the day. And I'll make that link available to you in the chat box towards the end of the presentation, and it's also in the schedule that was emailed to you along with your meeting reminder today. So with that out of the way, I'm going to take a minute to introduce our presenter for today. Her name is Kristen Woodlock. Kristen is a consultant at the National Council, and she currently serves as CEO at Woodlock & Associates, a consulting firm for nonprofits operating health and human service programs. Her experience includes delivery of direct care in hospitals, building and sustaining leadership teams, and executive operations and policy work for county governments, state governments, and nonprofit agencies. Kristen began her career as a registered nurse working in emergency medicine in New York State. And following that, she was the executive deputy and acting commissioner of the New York State Office of Mental Health, where she oversaw the largest public mental health system in the United States and helped author the Children's Plan. She was also a crisis CEO at FEGS Health and Human Services, where she led FEGS through an executive leadership change, financial crisis, and Chapter 11 bankruptcy protection. She's been recognized by both peer and family organizations as a partner in the delivery of person-centered and family-driven services, and is a personal friend of NIAPRS, so we're super happy to have her here with us today. And with that, I'm going to turn it over to you, Kristen.
Great. Thank you, Daniela. Appreciate that. And a hearty welcome to all of you. I think we have almost 80 people on this, so I am really grateful that you're taking time out of your day to join us. And I must say I'm disappointed not to be able to look out and see 80 faces. So know I'm virtually trying to connect with you. So thank you for joining us. I'm going to try as we go through creating value propositions today to achieve a few goals that have no doubt changed. At least I know they've changed for me as it relates to the COVID-19 pandemic. So I'm going to try to talk about value propositions, but also try to weave in how you might be able to use the strategy for talking about how you do a value proposition, not just for value-based care, but also for things that you might be doing in your organization to think about proposals or innovations that you want to try to support with government partners, with philanthropic partners. So no, I'm going to try to walk that dual track. And as Daniela said, we really want to make sure that we answer questions and we make this relevant to you. So I'll go through the presentation and then we'll have ample time to be able to do some Q&A and talk about things that are on your mind and are important to you. So make sure you're chatting those in, please. So I love this quote, and I think it is so apropos when we talk about value-based care and value propositions, in that as we think about knowledge and learning how to do this today, it really is only rumor until it lives in the bone. And what does that mean? Um, that doesn't mean you need to take a vitamin. That doesn't mean you need to go work out, but it means you need practice, that you really need to think about value propositions, think about what you're good at, think about what your skills are, and practice that. And over time, you'll get that to the place where you've really created knowledge around how to do value propositions. So this is not only a great quote, but it's also a reminder to take your time and really iterate and practice this when you think about value propositions. So the first stop on value propositions is to make sure that you have something that is actually going to be suitable for value-based payment. And again, if we're trying to think kind of broadly in the pandemic environment that we think of ourselves in, if I am going to be writing a proposal and talking about an intervention that I'm able to do, is it really geared to that payer? So first, let's get clear on what these distinctions are. So public goods are things that oftentimes, government, philanthropy have funded to really create that social safety net and that social fabric. So these are things that are available to all people, all populations. These could be things like a drop-in center that we have on Main Street, that we want everybody to be able to come in and feel welcomed, and maybe we have some crisis elements to that. This could be something like youth development. We want to make sure that young people in our state, in our community, have access to social emotional learning and have access to healthy foods and other kinds of academic opportunities and safety and housing. And these are broad general concepts and constructs that we want to have be open and available to a wide array. Public good initiatives and interventions can also have a much longer time frame to them. So for those of you who are listening into this who work in the prevention area, we know that sometimes our action today to try to prevent someone from smoking or to try to prevent the development of chronic disease, those things can take time to really pay off in rewards, right? If we spend $1 today trying to prevent something, we know in 10 or 15 years we can have really monumental impact on people's well-being and lives, but also on the financial cost of their healthcare, right? So those are the things that are sort of public good. And public good as we start moving towards value-based payment, they're not going to go away, not all of these. So they remain important in terms of that social fabric and social safety net. So how is a value-based payment different? Well, first and foremost, a value-based payment initiative or innovation is going to be designed for a particular population. So if I am designing this for Blue Cross Blue Shield, and I design something that has open, access, like we just talked about, like a drop-in center, and everybody who has any kind of health insurance is going to be able to come to that drop-in center, probably Blue Cross Blue Shield is not going to be as interested in funding that, right? They want to focus on their members and their members' healthcare and supporting that in some way, shape, or form. So a value-based payment innovation is really tied to that particular payer that you're having conversations with. It's also got a measurable impact that's going to be important to that payer, and usually in a short time frame. And while there's not a hard and fast rule that it has to be less than a 12-month time frame or a 1-year time frame, I found in my work with coaching people on value propositions that that's a good benchmark to look at. So if I'm going to put a proposal, again, thinking about like to Blue Cross Blue Shield, I want to make sure it's relevant to their members, it's something that's important to them, and that if they invest $1 with me, I'm going to be able to show them impact within a 12-month period. So what might this look like? This might look like, a Meals on Wheels program that also includes a checklist for determining senior wellness and potential risk of going to an emergency room. So I would be able to say to an insurer, not only are they going to get the meal through Meals on Wheels, but we're going to do a check to see how people are doing in their chronic disease management. And if we see something, we'll notify you so that you can reach out to the primary care doctor and avoid an emergency room visit. Something hopefully many of us on this call are familiar with, recovery coaches that are in the emergency room to improve engagement in outpatient services, whether those be mental health, substance misuse. Those are things that can further engage people in outpatient care and reduce repeat admissions to the emergency room or to inpatient. So those are things that would be a value-based payment. So in sort of a lightning round, again, if I could see all of your faces and you could raise your hands, I would say, all right, what about these three that we have here? So we've already talked about recovery coach. Recovery coach is definitely something that can be a value-based payment or value-based proposition. What about substance use prevention? And I'm thinking some of you are probably saying, well, I could see that as something that I could come up with an outcome in a year. I will tell you that one is more challenging. And later on in the presentation, I'm going to actually share with you a value proposition from Western New York that really shows how a substance use prevention provider got creative and sort of threaded that needle and found the way that they could begin to work with a primary care practice around substance use prevention. Similarly, peer advocacy. So peer advocacy is one of those that can be sort of in both ways. It depends on how you write the presentation up. So if you're thinking about peer advocacy from the standpoint of I want to be able to support people in a warm line 24/7 and anyone in my community can take part in that, that's something that's probably going to be in that public good bucket. But if you're talking about doing peer advocacy to improve health promoting behaviors, to improve engagement in outpatient services, for instance, that might be something that you're able to carve into a value-based payment proposition. And that's something that when we get to the interactive part of this, if you want to have some conversations and go back and forth around, is what I'm thinking a public good or is it a value-based payment proposition? That's something that we can talk about at the end of the presentation. So we also need to pay attention to the environment. And right now I'd probably put another arrow on this that was like a little bit of a curly Q that was like the COVID pandemic, right? Because I think that's further changing all of these financial levers that we have here in New York State. But this complexity is something that's very important as you start thinking about value propositions and talking to payers. So let me just orient you to this. So you have the blue line, we're going to sort of go from the top to the bottom. So the blue line that says health, behavioral health, social services, and child welfare regulations. And that arrow is pointing back towards a volume-driven system. And that's very true. We have an extensive network and web of regulations here in New York State, as do all states across the country. And we've been very good at adding regulations. And certainly in the area of COVID-19, we've shown how quickly, when we are in a crisis, we can modify and change those regulations. But up until this COVID point, those regulations have been really challenging to people who want to begin to look at value-based payment. And you might say, well, like, why is that? And I could probably keep you here on this presentation for about 4 hours and try to explain that. But one of the biggest challenges to having a very highly regulated structure and starting to think about value is that that regulatory structure really is guided by a certain set of compliance and actions. Did I have a treatment plan? Did I follow this procedure? Did I document it this way? And value is really inherently about, did I achieve that outcome that I told you I was going to achieve in a high quality way? And there's really an inherent tension between those two. So again, as you begin to think about doing a value proposition, you want to think about how the regulatory environment in the area that you're working on, is that a factor? And if it is, how are you going to try to counterbalance that? The gray arrow to my screen right of that is private equity and corporate investments in healthcare and social determinants of health. So SDOH in this case is social determinants of health. So we are seeing more interest in having different kinds of investment in healthcare, where people are interested in the human aspect of that, but are also interested in the financial investment and potential profit that they can make in that as well. And that isn't necessarily a bad thing, right? It's how that tool is used. So we may be able to find that rather than looking at a health plan or rather than looking at a Medicare Advantage plan to take our value proposition, we may be able to come up with something where we can attract private equity or corporate investment in healthcare or in social determinants of health, like housing, like having adequate areas for exercise, access to food, those other elements. We may be able to leverage that movement in a way of supporting the work that we want to do. Next, we have value-based payments to Medicaid managed care plans and move more towards value-based payment contracts. We certainly do see that moving towards value. I think a challenge for us in the behavioral health and community-based organization and social determinant of health sector has been one of scale on this, that there is, there is a movement in the market for larger providers who are able to have a significant number of members that are involved in some of these issues. What if I'm a smaller provider and I'm only going to serve 100 people, and those 100 people are split again, across a couple of Medicaid managed care plans, right? Then that becomes more complex. There's also probably, this was back of the envelope numbers, but there's got to be at least 15 billion in state funding to, programs, practices, contracting, that New York State funds out there to a variety of programs that's still contract based. So that's another thing for us to remember as we think about financial incentives. There have been Medicare advances with actually Medicare Advantage plans in value-based payment. And then lastly, philanthropic investment is a little bifurcated. Much of it is still in a volume or performance contract-based way, but it is moving slowly towards how can philanthropy be used as an adjunct to some of our work in really advancing value-based contracts with providers. So ideally, rather than having this sort of chaotic mix of arrows, we'd ideally have something that, as we were starting to think about how we're going to package our work for value propositions and value-based payment contracts, we'd have these arrows sort of pulling in the same direction, so that we did have more of population health as a unifying strategy. What does that mean in practical terms? That means that individuals who have a serious mental illness would no longer be passing away due to chronic diseases 25 years earlier than their peers, right? We'd have a more holistic approach to thinking about population health. Likewise, it means that and again, COVID is a great example of that, during a time of this pandemic, that we're really paying attention to the trauma that people are experiencing, and we're interacting, we're giving them ways of looking at emotional regulation, looking at mindfulness, looking at dealing with traumatic experiences, developing positive compensatory behaviors, so that they don't end up with greater chronic disease progression in the future. That there is alignment. So when we think about regulation, we think about government funding, we think about managed care plans, everything's sort of pulling in the direction towards trying to create better value for people. This would be very data driven, right? So it's not as much, I have a pretty good idea of a pretty good drop-in center that I want to run. I think you ought to fund it, right? It's what is the impact of that intervention? How are you going to measure that? How are we going to know if it's successful? And if it isn't successful, we're going to stop doing it, which is a very different pathway and trajectory than much of our program development has been in the past. In this scenario, value equals outcomes over cost. So as we've been talking about that, if I invest $1 in you, what are you going to be able to provide? And is that something that I determine has value to me, so that I'm going to fund that? There's probably a lot of value you could add if you gave, every behavioral health provider $1 million to serve 10 people, right? But that's just not going to be an equation that somebody's going to support financially. So you have to look at that balance from the eyes of the payer. And then really balancing that long-term investment and the short-term gains for population health. So that's a little bit of the lay of the land before we jump into the steps. And I've tried to make these steps as simple as possible, so that they're something that to my point about, you have to sort of, get into the dirt and, start trying to build something here, and it takes some time to make these understandable. You can start to work on them, and then we'll go through these steps, and then I want to share with you some concrete examples from around the state and around the country that can help you sort of see how these building blocks get put together. So the first thing is to really introduce your organization. Ideally, when you start to think about sending in a value proposition, ideally you've started to build a relationship with that potential payer before you start committing, pen to paper or start typing away at your keyboard, right? But if you can't, then you really want to think about this background section as a way to introduce your organization and really quickly grab my attention. So one of the first challenges that I see with background is people take way too much space in their document to cover this. So again, in my work, I found it most effective if a starting value proposition is no more than a couple of pages. So you're talking, 2 or 3 pages to do all of these steps that we're going to talk through here today. So in this background section, you don't want to just cut and paste from your website that says, back in 1894, we started out, and then in the 1950s, and then in the 1990s, and then we did this, and then we did that, and, walk down the garden trail. You want this to be something that's pretty crisp and compelling, and that really shows how different you are from the other 14 agencies that maybe reached out to me yesterday, right? Why should I move you to the top of my inbox? Why should I read your value proposition? And try to demonstrate your understanding of value-based payment, right? So it's not as much, again, about that laundry list of here's our history, but this is my organization. We are really committed to reducing chronic disease progression. Or we are really committed to making sure that people are able to live healthy in the community and don't need to go unnecessarily to the emergency rooms. What is it? What is it that you really are passionate about and that you want to start working on? And you may talk about what you've been able to do in the area that you're going to focus on for your value proposition. And again, we'll show you some of these as we move forward today. So next, you want to quickly get into what is the concept. So this could be a problem statement, of something that really is not sort of working in your current local health system, that's causing too many people to potentially overdose, that's causing people to go into the emergency room. Maybe that's keeping people from engaging well in the services and supports that are going to keep them healthy. So it can be something, again, that's not working, or it can be an opportunity to really rethink and do services very differently in a way that's going to improve a health outcome. So this doesn't necessarily have to be positive or negative, but as you start to sit down and write your concept, you really want to begin to think about it as a start to storytelling, right? And what is it that you're going to do? So you want to tell this story using whatever local or national data experience that you can get your hands on. So try to ground it in research where you can. If let's say you're doing something with an older population, and one of the issues is the fall rate for individuals who are over the age of 70 or 80, you might want to take a statistic that you have nationally or locally about how that's resulting in significant negative health outcomes, and we're going to try to focus on that. And again, we'll show you some examples of that. And then you want to make a compelling argument for why this thing that you're going to do, why should I sort of be thinking about this, right? I probably have a lot of things that are on top of mind for me. Why should I sort of drop those things and maybe, decide I'm not going to do a couple of other things because you've made such a great case about why this is affecting my members. So that could be something where it is financial. It could be something where it's potentially I'm going to get more people who want to join my plan or more people who want to join my provider network. So having more people enrolled might be of value to me. Maybe it's health outcomes. Maybe my health plan has really been focused on diabetes management, and you have a solution for that. So sort of play to that strength in terms of why this is so important. And wherever possible, when you're starting to think about using the diabetes management as an example, if that's something that you really feel you have a great solution for, try to identify the payer or the funder who has that same interest. It's much easier to try to get uptake on your concept if you're working with somebody who's also interested in the same segment that you're trying to produce a value proposition for. And then really create some urgency around it. What's the potential cost to me as a payer for not taking this piece up at this time, or what's the opportunity for me? Again, understanding that people who you're doing a value proposition pitch to probably have had 5 other pitches that day, or quite a few others scheduled, and have a lot of projects that they're managing. So you really want to make yours distinctive, and you really want to make yours stand out. Next, thinking about deliverables. So you really need to, in any value proposition, talk about what is it that we're going to influence. And even if you don't have an electronic health record, you don't have the best data system on the planet, that doesn't give you a pass from trying to address this. Of if here's who I am, here's what my concept is, this is what I'm going to deliver for you, and here's how I'm going to track that, right? So you need to be able to talk about what it is you're going to look at in terms of reporting and impact, and make sure that they're developmentally appropriate, right? And what I mean by that is not that they are age appropriate, but more that it's something that you are able to actually deliver and provide. So what might that look like? If you're able to look at doing something with an electronic health record, that might be on one end of the continuum, where you're able to talk about time to care, you're able to talk about engagement, you're able to talk about dose of treatment, other factors, use of the hospital, you may be able to report on that. On the other end of the continuum, you may be able to talk about things like engagement, keeping someone's contact information up, who's maybe very difficult to engage by the plan, and they might not be able to routinely get in contact with a person, and you may be able to do some of that outreach, right? So it could be actual contact information or contacts with people that you're going to report on and you're able to deliver. So you need to think about that in relationship to your plan, and again, also in terms of your capacity to do data tracking. Next, really walk me through how you're going to do it. So I understand, just sort of repeating this again, I understand who you are. I understand what you're trying to do with your value proposition. I understand what you're going to measure. What are your methods? How are you going to do that? And this one is also interesting when you think about trying to do this, this whole entire value proposition in a couple of pages. You want to make sure that you really are building your credibility. So when I'm reading this, I don't have to be an expert in your field, but in reading it, the gears start to click, right? And I'm going, okay, I understand they want to try to keep people out of the hospital, or they want to improve engagement rates. Here's what they're going to do. Okay, I've got their steps. It makes sense. It hangs together. It passes the sniff test. I understand it. This sounds really interesting. This is something maybe I've always wanted to try, right? So again, you're telling the story, but make sure you also do that from the payer's perspective, right? So you want to try to avoid jargon, avoid acronyms, avoid a lot of what I would call inside baseball language, stuff that we know, but the payers may not be at that level of detail or familiarity with. So when you get to particularly the method section, it's great as you start to write this to have a colleague who's going to be your designated reader, for example. And the designated reader is going to be somebody who's going to read this and say, wow, I'm not sure people really are going to understand this. And can you go back to the drawing board and come back with something different? So I think that's something that would be really helpful for this methods section. And then lastly, we talk about return. So I like to say this from really, why should I open up my wallet? And as I'm working with people, sometimes I can find when we first start talking about value propositions, the person who I'm working with is so in love with and committed to their value proposition that like they're the most excited person in the room about it. And that's something that you really do have to guard against as you start to think about this, right? It's not just because it's good for mankind. It's not just because, the earth will be a better place because of this. It's really because of this intervention, Why is this something that I should invest in for my members? Why is this something that again, I should open up my wallet and connect with you to make this work happen? So to do that, you have to talk about, what's the cost? So, and really be transparent in that. And that too is an interesting exercise when you get down to how could I determine that cost? I want to have my care managers doing this. How do I break out what that cost is? That's something that you're going to have to come up with a strategy to be able to do. And then how can I potentially determine what a return on investment would be for the payer? I don't have access to the rates that they pay. I don't have access to their hospital data, to their clinic data, to their hospital data. How am I supposed to do that? So there are some tools, and one that I'm happy to share with NIAPers that I did with some colleagues at Montefiore, that was a pretty simple Excel spreadsheet that talked about, what are the costs for me to do this particular program, that looked like probably any budget that any of you have ever put together, with personal services and other than personal services, et cetera, admin costs. And then started to think about how many emergency room visits do we think we could prevent by doing this, or how many inpatient days, and used a proxy measure to begin to track that. I think what I found in working with a lot of people is that we're not sort of there yet of trying to plug numbers into a spreadsheet in terms of looking at return on investment. There's also, for those of you who feel like you're ready to run in the Olympics, the Commonwealth Association put out a return on investment calculator as well that's exceptionally detailed. But that's something that you can use if you want to go to that level. Again, in my practical experience and actually working with people boots on the ground, I found payers much more willing to, what I call, co-design that return on investment. And that is if they really are bought into your concept, your methods, your deliverables, and your transparency in terms of return. Here's what it costs. These are the things that I think will be of value to you. Here are some starting estimates and thoughts about what a return on investment might be for you. People are really willing to come to the table and start to think about how the payer can even help begin to look at that return on investment. And then lastly, in terms of return, just be realistic with this. I've been at sessions where people have brought together payers and people who are doing value propositions, and some pretty small organizations have brought value propositions that were about at this level. I really am not exaggerating that. If you give me $100,000, I'm going to save you $3 million next year. So that just seems like a little off or a little weird, right? So just make sure that as you start to look at return on investment, that you really do under promise and over deliver, because that's a really important element to your own credibility with the payers and to building trust and building that connection that can evolve. So I want to now try to take those concepts and show you them in some, these are real, the next pieces here in the presentation are actual real life work from people in New York and around the country. So you can see what these look like. I would really encourage you not to copy verbatim all of these, but really use them as examples that you can talk about with your team to say, how might we do this? How might we use different language? How might our format look? What might our cost be? Maybe we want different deliverables. But because there really isn't a body of work so far that I've been able to find that says, here's how we write value propositions, I think these are helpful as you get started in starting to try some of these on and figure out what might work for you. So this first one was one that I worked on with the Mental Health Association in Chautauqua County, who was interested in doing recovery coaches. And they had recovery coaches and were trying to have a hospital that they were working with think about them more broadly. So think about them in hospital units in the emergency rooms, but also, be open to thinking about them in a clinic setting or in a primary care setting. And so what they wanted to do was share, this is what a recovery coach does. As you can see here, here are some particular places where you can use a recovery coach, and we want to just give you a quick taste of this is what a recovery coach looks like in these various settings. And then they moved on to say, what are some things that we're going to measure? And I think this one is a good example about this is not Medicaid data that's run, every quarter and it's updated. But one of the things that we could do via peer survey is potentially look at things like readmission to detox, avoidable ED use, readmissions for hospitalization. We could come up with engagement measures. We could update contact information with insurers, hospital, and PCP. And that's been something I've seen really be of value between what I might call more grassroots or community-based organizations and payers who are having a difficult time getting in contact and engaging people who are not as eager to engage in our services, being able to be that connection point. And then also talking about a RAP plan. So that's what this organization brought as a frontline piece to the hospital system. And this was a hospital as a payer, not a health plan as a payer. And then really talked about, in terms of return on investment, put a paragraph together that basically says, we know return on investment is important. We want to be a good partner in trying to figure that out, but that would be something that we'd want to co-design with you. So I think this one is important in really illustrating how do you use those 5 steps and sort of keep them where you're at as an organization, but yet really potentially open some new doors in terms of new conversations around the work that you're doing. So this next one is also a Western New York example. And this one I think is interesting for those of you who feel like, wow, given that you just went over, Kristen, the public good versus the value-based payment, I feel like a lot of what we do is in the public good category. Don't be disheartened by that. This is an example of a group that's been doing substance use prevention with adolescents. And when I first met them, they came to me with, okay, we want to write a value proposition. And if you invest in substance use prevention for young people today, in 20 years, you're going to have some phenomenal outcomes, right? It was one of those where you were just like, oh no, we're going to have to really work on this. But we kept at it and we kept talking it through and kept working the steps that we've talked about here today. And as we worked that through, we came up with some really great ideas for them. And so what they looked at, and you can see here where they did the background in like 4 lines. They talked about their concept, and their concept was really to say, what, we think our best connection is with primary care practices. It's probably not with hospitals, it's probably not with health plans, but in our community, there's only, 2 or 3 big primary care practices, and they are all struggling immensely with adolescents who are using substances and adolescents who are like experimenting with substances in their families. And, they don't know where to turn. They don't know how to, and don't feel comfortable with how to talk to the young people and their families. They're not sure about all of these other services and supports that exist in the county. And they are really feeling overwhelmed with this. And there's really significant concern about vaping. There's significant concern about overdoses. And the pediatric practices really feel stuck. So they wanted to try to capitalize on that and say, we can come in and we can be a help to you by offering a menu of choices. You could decide to have 1 or more of them, but there are 3 things that we can bring to your practice. First, we can do the screening and intervention tools for substance use, which have acronyms called SBIRT and CRAFT screening. So we can do that. And actually, if we can complete those, you can bill Medicaid for those. So, there's actually a payment stream for that. But we know how to do them. We know how to interpret them. We'd be able to do those screenings for you. Next, they had an evidence-based 9-month intervention program called Teen Intervene that really works with young people who are starting to use substances and helps them kind of get back on track and helps the parents and whoever's that the support people are for that young person to equally engage in that process. And lastly, they said, we recognize that you are fielding a lot of calls. You have a lot of calls with parents, with young people about how to deal with this, we can take those off your hands. So if you do have a parent or a young person who you want us to speak with, we can do that. And so what you can read through in here, and I'll let you do that when you get the slides, is the data points that they identified. And I think they did a very nice job of talking about what the data point is, defining it, which is also important. So if you say, for instance, you're going to do, community support referrals, what does that mean? It means number referred by organization, number connected to the organization, specify what it is that you're thinking in here. And then they also added responsible party for that because they planned on sharing that with the people that they work with. And then in terms of those three value proposition elements that they came up with, they defined what a unit is for each of them and then added in the cost. So for instance, you can see here to do the craft screening, it was $24 per screen. The Teen Intervene was $1,600 per youth for a 9-month package. And then to be able to do almost 9 hours a week of practice support, which freed the nurses, the doctors, the advanced practice nurses to do their work, their billable work, was $45,000 for a 1-year contract. So hopefully I think this one is interesting both in terms of, I think they really did a nice job in pulling together their value proposition. But I think that this one is also really interesting about that journey from something that is a public good into a value proposition. And they are actually working, last time I spoke with them, they're working with one of the pediatric practices in doing elements of all three of these. So it's really exciting. Some of you may have seen this. This is one that I know I've been touting and talking about for a long time. But I think this one, from Arms Acres, which is in the Hudson Valley, is another interesting piece in terms of return on investment that sort of looks at this from a different angle. So their value proposition really started out as much more of like a poster session. So what you see here is something that you might see if you went to a conference, and probably many of you actually did see this poster at a conference in New York State. But this is another opportunity for you if you prefer this kind of approach to introducing yourself and introducing your value proposition. This may be a way that you want to begin to do this. So you'll see that the headings are a little bit different than the steps that I talked you through. But in essence, all of the content is here. So this is another example of something that you could look at. And just these are some of the Arms Acres slides. But essentially, for this project, this was an inpatient, outpatient substance use continuum, and at baseline, less than 50% of the people who went to their inpatient program were showing up in outpatient, and that is not good, right? That is not a level of connection and consistency and continuity of treatment that we want to be achieving. So that was where they started. And what they did was they brought on 2 recovery coaches to try to improve that. And as they began to look at that, what they found is that they not only needed to bring in the recovery coaches, but they really needed to rethink the entire inpatient to outpatient continuum, from how the recovery coaches got introduced to talking to people while they're inpatient about the importance of outpatient treatment and recovery and what role that plays, and dealing with issues about how are you going to get there and transportation and all those other things so that support could get there for outpatient treatment. And they also recognized and really, I think, had highlighted how important it is for people to have support and multiple tries to get there, right? That it's if you don't make it on the first appointment, we're going to help you reschedule and make a second appointment. If you don't make it on the second appointment, we're going to figure that out and help you get there again. So they really rethought that continuum. And what they were able to do in a very short period of time is change that rate to the first outpatient visit from 46% to 100%. So, very impressive impact. And as you can see here from the numbers that you see on the slide, they've been able to really break that out in a very detailed way. So some of you, as you think about value propositions, maybe, in the first example that we showed, may have some general concepts and some very introductory basic things that you're going to track. Others of you may be able to get to this level of data yourself or with somebody you're partnering with to do a value proposition. that really makes the case. And I include these slides here because I think this really does make the case well and is something that's easily digestible to somebody who you would be doing a pitch to. So, I won't go through all of these. I'm more including these in the slide deck so that you can, you can see the impact and difference, if you have the recovery coach versus if you don't have the recovery coach. Again, these are just ways of making your case to the payer in a simple chart that, is really catching and likely to have them then read your 2 or 3 pages that you've sent to them. Again, just another graphic example that you could use. And in terms of return on investment, the Arms Acres folks actually did use a more of an Excel spreadsheet that looked at what are our costs, what do we project in terms of inpatient use that we avoided, and they were actually able to calculate that out. So, as you can see here in 3 relatively short bullets, they were able to say, without this service and the intervention that we did, we estimated that 65 people would not have been connected to care, and that each of those 65 people that had been released from inpatient, didn't make it to outpatient, would have at least had 1 emergency room visit and a series of inpatient days in that first year. And then they used factors for the cost of those ER and inpatient days to come up with a return on investment. So in essence, an $80,000 investment in this case would yield you $237,000 worth of benefit. So again, depending on the information that you have at your fingertips, you may be able to talk about this in different ways, and wanted to share with you some continuum examples. This one is again a different way of presenting it, and I tried to give you some some different templates and ideas that you can start to think about and start to try out a bit. And you'll see this is essentially 2 or 3 pages. This one is actually for a medical legal partnership. What I would draw your attention to on this one is more the table that's here about how can legal services help address social needs. I think they did a particularly good job in this table, which I know is impossible to read on this webinar, but you'll be able to see it, if you're able to look at the slide deck in more detail. But they took a pretty complex thing and said, so like, in a sense, why should I care about the legal needs and social needs? Like, what does that matter? What does that mean potentially for a medical concern? And we're really able to lay that out in a strong way. So if you have a concept, let's say you've come up with something that really is innovative and new and nobody's heard it before, you may need to come to a table like this to be able to quickly explain how your intervention is going to help with maybe the top 2 or 3 key health indicators that health plan is really thinking about. So just remember, as you're doing value propositions, and you're trying to cram everything into 2 or 3 pages, that it's not about, going on to your Word program and selecting narrow margins, right? So that you can fit more on a page. It's about how do you create spaces on your page that really get your message across in a really quick way. So I share these next 2 workflows, as potential strategies that may help you get started. Because another experience that I've found with groups that I've worked with is that sometimes it's hard to get the momentum, right? We feel like we know what we do. Okay, I've seen these steps, Kristen, like now what's the next thing we do? And I do find it's iterative, and it really is helpful if you can talk it through. So this is a workflow actually that I did for a National Witness Project Center, and what they really wanted in the end was they said, we can really be great. It's almost like community health workers. We can help people understand what their primary care doctors are saying to them. We can accompany them for tests and screening. We can help them read medical information and advise them on that. We can assess and resolve social determinant of health barriers like transportation, access to food, access to medication. But when we first started out, it was sort of all over the place. If you took all of these shapes and you jumbled them together, and we had to sort of walk through and say, all right, what would our workflow be? And sometimes I find creating workflows is helpful to getting your thoughts organized and understanding what the process is and being able to identify what those key elements are. And then once you get this workflow identified, then you can go back to those 5 steps and start working this for your own organization. Similarly, this is just another graphic that another team that I worked with found helpful. um, they were trying to figure out, okay, how, what is it that we are going to sort of advertise, right? We do a great job with engagement. We're really able to help people figure out how to get into their primary care practices. But what would that look like, right? How do we start mapping out what we're going to do? And for this particular organization, they worked with a primary care practice to identify people who had not been in for visits, to identify people, importantly, who were what we call attributed to them. So the managed care plan said, all right, you don't have a primary care physician. We're going to assign you to, Kristen Woodlock, primary care doctor. And I may never have met that person. So this organization, this community-based organization, was doing outreach to those people for the primary care practice, and then came up with some measures to be able to track that. So again, if you feel like you can just sit down and start writing using the steps and the process that I've talked about, that's great. If you feel like you need to start getting a whiteboard, or for those of you who don't know me, I'm a big fan of Post-it notes like this. Get some Post-it notes up on the board, or even if you're doing things remotely now by Zoom, get your team together on Zoom and have one person maybe typing away or drawing away, and get started with that. And I think you'll find that very helpful. So Daniela, why don't we check in and see if we have any questions? And if you have a question, this is also a good time to put that in the chat box, and we will do our best to get to them.
So Kristen, we do have one question that came in. Actually, we have a couple questions, but the first one is there any way that value-based changes can be implemented without specific measures of results?
I would tell you by definition, no. I think if you're, and that doesn't mean that work isn't important, but the whole idea of a value-based payment is that, there's an investment in doing something, you do that something, and then you have the outcome or output of that. So if I invest in what you're doing and you do it, and we have no idea what impact it makes, by definition, I would say that's not a value-based payment intervention. Maybe it's a public good, right? Maybe we just don't have the capacity yet to measure what that impact is. I think that it's fine to continue to do that, but you need to sort of put that in the public good basket. And while it's a challenge, I think, and I certainly would challenge everybody on the webinar today, and I challenge the people I work with, that I think value-based payment and thinking about that is really something that's empowering to people that we work with around really driving changes, right? It's not just about coming to clinic for treatment, right? It's about, am I getting better? Am I able to live my life more independently? Am I able to get that job I wanted? Is my chronic disease managed? It's not just, am I coming to clinic every day, right? So, I think that's how I would answer that question. And also, Daniela, sort of doing a riff off of that, I think one of the things that's going to be really interesting from an outcomes perspective as we look at this COVID-19 pandemic is, essentially, at least in my life here in New York City, it feels like everything changed March 1st. And soon after, we started to do televisits. And I think it's going to be very interesting when we start looking at data and impact to see, what is the clinical impact of no longer doing 45-minute in-person, sessions in clinic once a week, and really shifting that to something that's very different. Are people doing better? Are people doing better in terms of substance use or mental health outcomes? Are people doing better in terms of ER use? Are people doing worse, and what that is? I think that's going to be a very interesting, piece of outcomes for us to look at as we get further with COVID.
Yeah, absolutely. And then we have another question for you about how do we get potential payers interested in an organization's value proposition, and what steps would you recommend, especially for smaller, more grassroots organizations?
That's a great, great, great question. So I might start with a couple of things. You know, who I would do a scan in your particular world, right? In your particular community. And remember, now that we're all, and again, in my life since March 1st, we're all like super connected via video. Maybe your community changed. So think about that and at least be open to that. But think about who in your community is interested in whatever it is you're trying to do with your value proposition. And if you look around and you're saying, you know, geez, I don't think anybody's interested, I might reflect at that point about is it that I'm onto something that people haven't caught up with yet, or do I need to change what my intervention is? And that's something that I don't always find people take the time to do, right? This is what I do. This is who I am. You know, I run a drop-in center. I do peer support, or I do, you know, recovery coaches. And that's what I do. So until you figure out that you want a recovery coach, I'm going to keep knocking on your door. And I think that's not as effective as a way. So first, sort of think about who's interested in what I'm doing. And if you don't find somebody, I might think about who are payers that I might be able to partner with. So if I'm smaller, I might, rather than trying to go to Blue Cross Blue Shield, Health First, MVP, you know, name your New York insurance companies, maybe I try to go to a large behavioral health provider and see how I could augment their work that they're doing. So like a for instance, and I'm only using this as an example, but like let's say you saw that presentation from Arms Acres and you were an entity that is training, you know, recovery coaches and peer supports. I might go to them and say, I'd love to be your pipeline for, it looks like you're doing some fascinating work with that. I'd love to be your pipeline for creating that workforce. Let's talk. So maybe that's your value proposition of really, you know, starting in and partnering with a particular provider. You know, you might want to think about a hospital that you know is in your system, like the MHA of Chautauqua County was working with a hospital around that. So don't just think about payers, think about other people who might be a little bit bigger and might have more of the conversations with the payers, and how you can potentially dovetail within that. But again, if you're not finding interest in what it is that you're trying to sell, then I would do some of that reflection about, you know, what is the biggest problem in our community, and how are we gonna deal with that? So like a fabulous one that I'm seeing right now, because now my brain like thinks in value propositions. Just with being active here in New York City and some of the COVID response efforts, one of the things that I'm hearing is a huge challenge that I think we're all trying to figure out is, you know, how do we do this physical distancing with and work with people in a way that is consistent with our values, when maybe they don't understand the importance of physical distancing, or they don't want to do physical distancing. You know, what are our choices between letting them get sick, or trying to get law enforcement involved, or, you know, committing someone being a danger to themselves or others? Like, what's that in between, right? And, you know, we all know about motivational interviewing and other strategies, but it's kind of different in COVID. So like, that's something that I see anyway as a huge business opportunity for somebody, right? Because there's gonna be a lot of people who have that problem and who are interested in solutions for it. So try to think through with your team and with your communities ways of identifying those really big problems, because those are things that tend to get picked up more quickly, because I know I have that problem. You're not telling me I have that problem, and you're bringing me a solution, you know, and that's fantastic.
So one more question that just came in, which actually dovetails on what you were just talking about. So instead of talking about like who do we reach out to, but more specifically, how do you know who to contact on the payer side? So people are saying it's often a challenge to find the right person to sort of get their ear, and how do you know who to identify?
So again, I think that takes I think that takes some time. I would start with some of your trusted contacts. So, I know because I feel like sometimes I'm older than dirt, I would think Rolodex, but it's also probably like your cell phone, right? Like, who do you know that knows a lot of people in your community and could say, I want to run something by you. Here's something that I'm thinking as a value proposition, here on Long Island. But I'm just not sure who to talk to about it. Try to find somebody in your network, and it may be a couple of steps off, right? You may know somebody who knows somebody who you can have coffee with, or you can get on a Zoom, assuming we're physically distant, you can get on a Zoom with and say, who do you think might be interested in this? But the key to that is having the idea, right? Because if all you're doing is you're saying, like, who's the person I should call at Health First? And if I was the person who was having a Zoom meeting with you or coffee, I might say, well, like, what do you want to talk to Health First about? And if you say, I don't know, I want to be helpful to Health First, and I want to have a contract with Health First, you're sort of starting in the wrong place. You want to start with really, what are you able to bring to the table? And if you don't know what to bring to the table, then again, I might start reaching out to some of your partners who you've been in contact with. If you're a provider agency, maybe you reach out to some peer agencies or some community-based organizations, churches, other social determinant of health providers. Reach outside to others and see what people are thinking of in terms of problems and solutions. And that can be a way to start getting some of the problem identification and problem solving together. But it very rarely happens with, here's the number of person or the name and number of the people to call at a particular payer. You have to start building that with connections and relationships.
All right, great. Thank you, Kristen. So no other questions are being chatted in, but I have a question for you.
Okay.
So my question is, who do you put on your value proposition team if you're an organization? Like, who would you suggest be part of that think tank for your organization to put all this together?
So I think in the early phases where you're trying to start writing and you're trying to start using some of the tools that we've talked about today, I think you want to have a pretty decent sized group of people who are representative of a variety of aspects of your organization. So I think of this a lot, which you can probably tell from the slides. I think of this a lot like doing workflows and process mapping, right? So if I was doing this, I would want to have people who are, representing people who receive services. I'd want to have, my leadership team in it. I'd want to have my finance person involved with it. I'd probably want to have, if I'm lucky enough to have somebody who does communications for me, have that person on it. Because you want people who are thinking about things in different perspectives and different words to run through that. Because somebody might be really good at talking about what the concept is, but they might do it from very much an inside our world language. And if you have somebody who's working on communications, they may be able to come in and help you edit that and write that in a different basis. So I would think more broadly to start, and then you're going to figure out who's going to be responsible for maybe writing or editing which sections that you're going to do. And I think this is also, doing value propositions is a great opportunity to have, like a fresh reader come in and read it. So, that can be, maybe your neighbor who is is a professor at a local community college, or it can be somebody else in your organization. But once you start coming up with drafts, have somebody who's not invested in it read it to make sure that it's meeting those goals that we've talked about on the webinar today.
Okay, awesome. So you've got about 5 minutes left before we join the other room. So if you wanted to start sort of wrapping up, I think this would be a good time.
Okay, great. So, I think maybe taking this, and Danielle, let me know if there's any other additional questions. We can certainly try to incorporate them into the last minutes here if we need to. Feel free to cut me off and toss one of those in.
Okay.
I think just as we think about value propositions, if I had delivered this presentation to you today and the pandemic hadn't happened, I think we would find a very different set of conditions going forward than we find ourselves in today. And so I might advise you to start thinking about value propositions just in ways of how can your agency do a few things as you begin to think about the pandemic. So one might be, how do we look for some of those new opportunities, like the one that I just like came up with off the top of my head, right? How do we offer supports and tools and coaching to help people figure out how to physically distance and social isolate and quarantine and all of those other things, with individuals who might have a significant mental health issue or substance use issue. How do we do that? So like maybe you use this process for a new sort of pandemic related business opportunity for your organization. And then as we think about value propositions, there's so much going on right now that if your team was amazing and diligent and did everything that we've talked about today and wrote up a value proposition and tried to get it in front of a hospital system or a health plan, in the next probably 6 to 12 months, unless you have a relationship with them and it's something that's immediately relevant to them, it's probably going to be a difficult lift, just because of the prioritized focus on the pandemic. So, be patient with that. I'm convinced that value-based care and thinking about things in terms of outcomes and value instead of volume is like here to stay. That it's very hard to go back to, just sit in the seat and we'll get a visit and life is good once you've understood that the health system can be driven around outcomes for me and my engagement and things that are important to me. I think the world will spin back to this. So it is good time to practice and continue to work on that. I also think you can use these tools and techniques if you're doing grant writing, if you're doing, justifications for your services, or you're trying to think about how you might reconfigure. Hopefully we don't experience, significant cuts in our sector and in our fields. But, if we do, how do you think about retooling and reprioritizing and moving into more of a volume-based, moving away from a volume-based system into value? Danielle, you have one more question?
Kristen, I do. I was just about to interrupt you. So yes, I got another question. It is, do payers give preference to propositions that involve collaborations among service providers? What's been your experience?
I think it probably, I've seen the most excitement by what is it that you're actually going to do, and do I believe that you can do what you say you're going to do, which probably could be said more articulately than I just did. But it mostly it comes down to substance, right, and believability. But that being said, if you have a good concept and you're credible in what you're doing, the more people you have that are involved, meaning the more of my members that you're going to serve, and the more you're collaborating with people who are key in my network, I think that's definitely an advantage. But if you just come to them saying, we're really good friends with 5 or 6 of your providers, you should fund us, like that's not going to work, right? So it's substance first, and then it's that networking and connection.
And as you were speaking, we just got another question. Can you speak to some ways about how to get unit costs for behavioral health?
So,
pretty good question.
So the first thing is to get to know your finance people, right? And you've probably been walking around, wondering about them, but they're actually good, smart people, and they have an important role to play in our universe. So I would do a work session with your finance people to really say, can I just borrow you for an hour or two, right? I want to talk to you about this concept that I have. So here's what it involves. Here's the staff time. It involves, let's just pretend we're not in a pandemic. It involves, a fair amount of car travel, and so, here's my costs. Help me figure this out, right? So start from zip, right? I have no costs. What's it going to take me to have 2.5 FTEs? This is the kind of person. Here's my other costs. Figure that out, and then you can start to think about, all right, what's my impact? How many people am I going to serve? And that way you can start looking at unit costs. I don't know that unit is as important as cost, right? And cost for your particular value proposition that you're going to write up in the way that, again, we talked about it. But I would really suggest sort of separating yourself from your city, federal, county, state contract work. Don't think about this as well on my CFR. You're like, no, 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 no. Go, just start with zip. Here's my value proposition. Here's how I'm going to come up with the costs.
Okay, so I think if you want to just do the last minute or two of closing remarks, and then we'll all, I'll give some folks instructions on how to join Harvey for the closing remarks for the day.
Great, great. Well, I think I'm relatively tapped out of good closing remarks, but one other thing that I will share with you, and it is something that I'll be happy to share with NIAPR so they can include this with the slide deck. One other tool that I tried to create for organizations to think this through is what I call a distinctiveness wheel. I don't have that on the screen now to show you, but just we'll talk through that quickly. It's a wheel that you can talk about with your group about thinking about what your mission is and how does your mission need to change when you think about going back to the public good versus the value-based payment. Do we need to update our mission? Do we need to think about our expertise? Do we really have expertise if we're going to do that engagement? Do we have expertise to engage people or not? What are our locations? What are our data systems? How do we look at costs? But it's just a little quick graphic that you could potentially use in a staff meeting to be able to, to think through organizationally. How prepared are we for value-based payment in terms of the work that we do and sort of the tools or elements that are needed to come up with a value proposition, as you begin to go forward.
Okay, awesome. Thank you so much, Kristen. So folks, I just want to say thanks for joining us today. This was a great session, a great second day to our second day of virtual seminar, and we'll hopefully see you again next Tuesday for the last day. I just put in the chat box the link to the Zoom meeting where Harvey is right now, and they should be finishing up. So hopefully we'll see you all in there for Harvey's closing remarks for the day.
Danielle, I'm not sure.
Take care, everyone.
It looks to me like the link is to me only. Can you just make sure you've got that to everybody?
Oh, I'm so sorry. Yep, I'm going to do that right now. All right.
Teamwork makes the dream.
There you go. Yep, perfect. Thanks so much, everyone.
Bye,
have a great day.
Be
okay,
well.
bye-bye.
Bye.
Take care.
Thank you, Kristen.